Some of my paramedic friends turned RNs. We was talking about how we didn't have an accurate view of nursing before we became nurses. So, as I mentioned in part one, we all kind of moved around to different units before finding our fit, and some of us still haven't. For me, I have experience in the ED, step down, critical care, surgical services, endoscopy, care coordination, and case management. So, over the next several podcasts, what I'm going to do is share with you just the workflow, environment, the hours, the positive and negatives of the areas that I work. And this is just from my experience as being a medic, and I think that's the most important. So, in this episode, what I really wanted to talk about was the surgical services, mainly pre-op and endoscopy. So, welcome to my podcast. As I've mentioned, over the next several podcasts, I really wanted to share with you just my experiences in different areas because it's sometimes hard to get that realistic view. So, part one, I talked about my emergency department experience being in the trauma center and being in the standalone ED. I wanted to talk about the surgical services aspect and endoscopy, which we call endo. But mainly in the surgical services, is mainly the pre-op perspective. Now, keep in mind, you have pre-op, you have the operating room, which is the OR, and you have the PACU, which is the post-anesthesia care unit. Mainly, I wanted to talk about the pre-op. And the reason I wanted to talk about these two is because they both have the same process, which is pretty much pre-admission, consent, procedure, and post-recovery. The only difference is that in the endoscopy or endo, you do your own post-recovery in the endo, whereas in pre-op, they actually move to a different unit called the PACU, post-anesthesia care unit. Now, these units don't take new grads. You need experience, and I'll explain why. But your experience as a paramedic could potentially get you into these units even as a new grad. But in my experience, I would say you probably need a little bit of flow experience or ED experience before you move into these areas. And I'll tell you why. So for pre-op, what was my workflow like? To me, the workflow was really fast paced in the mornings, but it was really slow in the afternoon, or maybe slower because usually they add some inpatient cases from the ED or from the floor. But usually it kind of depends on the surgeon schedules. So typically the way it is at where I worked, it was 11 operating rooms and different surgeons operated on different days. You may have ortho may come in to do surgeries on certain days. Bariatric surgeries were done. Maybe, all different types of surgeries. It may be thoracic, cardiothoracic. It just really depends. But the main thing that it was 11. And so usually when you come in that morning, usually surgery usually starts about, I think it was 7:30 first starts. And so your patients usually have to come in a couple of hours early. And usually what happens is on that, you usually have two patients and you have to get those patients ready. And so what you had to do was get them into the room. They have to sign consents, change clothes. You have to place an IV, and we would give pre-meds, which we call enhanced recovery after surgery. These meds can be anywhere from something like Tylenol, and it just kind of helps with the pain for when they get out of surgery. You're not having to give them so much pain medications. And the anesthesiologist would normally give them a briefing. Depending on the type of procedure they're having, like if they're having an ortho procedure, you may have a nerve block to where the anesthesiologist, you may pre-sedate the patient, give a fentanyl combo and sedate the patient and cut off the lights and using a ultrasound machine, and you're assisting the anesthesiologist into inserting that needle in a certain place and administering either ropivacaine or bupivacaine and just to kind of numb that area or to numb that nerve. So if they get any gastric surgery, maybe a gastric bypass or any other type of bariatric procedure, they would can get a nerve block. Or if they have an ortho procedure, like mentioned earlier, maybe they fractured their arm or fractured their hand or fractured the leg, then you're able to numb those nerves. And or maybe they may have issues with their blood pressure. They may get an A-line placed. Then after that, usually the circulator nurse, which is the OR nurse, and the CRNA would come get them around surgery time. So as mentioned earlier, you normally don't have but maybe 2 patients at a time. And so the environment, to me, is usually fast paced but you only have 2 patients at a time. So as mentioned, you're kind of working on schedule. They have to be ready by their scheduled time. They're supposed to show up 2 hours early, but most people, sometimes an hour and a half. I've seen them literally show up 45 minutes before the surgery, and it's a lot of work to get them ready during that time. But you work a lot with anesthesiologists, you work a lot with surgeons, and you work a lot with CRNAs. And so the hours I worked were 410s. I did Monday, Tuesday. I was off Wednesday. Worked Thursday, Friday every week from 6 to 4:30. Those were my hours. We had some people that worked 5 days a week, from 5:30 in the morning to 2 o'clock in the afternoon, and some people worked 312s. There was a lot of nurses there in pre-op that had 15 to 20, one even 30 years of being there in the hospital system. And they had a variety of backgrounds from the ED to the ICU. Now, I did have on call, but the on call was mainly to help the PACU if they get a call out or if they get emergency surgeries during that night. They may not be able to recover those patients in the PACU. So I did have that experience of having to do on call and to help out. But I think what I like mostly about those areas is that during the weekend and during the holidays, being that there's less, they're not running 11 ORs. They may be only running 1 or 2. So they don't need as many people. So most of the time, most of the holidays, even if you staff for them, you'll probably get them off because they don't need that many people. And people volunteer to kind of take on those holidays. Now, for us, endoscopy to me was the same as pre-op, especially the environment, the workflow, and the hours. The only difference is that in endo, they don't do nerve blocks, and in endo, they recover their own people. But with endo, the hours, they didn't have on call, and also they didn't work weekend or holidays, which was good. So, what are some of the positives and negatives of working in those areas? These units sound easy, but you would need good assessment skills, especially if you wanted to work in these areas. And here's what I mean by that. You have to be to pick up on a patient's history to see if they've taken anything like daily aspirin or any blood thinners, because you need to verify if they took it. If they took usually they come to what's called pre anesthesia testing, and they get labs done, and they get a briefing before they come in for surgery, usually about a week or two before, and they are told to withhold any medications, like maybe their blood thinner for that morning or their aspirin for that morning. But some people, due to creatures of habit, they will still take it, and you have to be able to ask those relevant type questions of any medications that may put their life in danger by getting anesthesia, by getting anesthesia. Also, think about this: when they're doing procedures like nerve block, or they may you're gonna have to sedate them, which means they need to be on a monitor, O2, and I've seen people bottom out just from Versed. I've seen their blood pressure tank. So you have to respond. Again, one of the positives is that every patient gets an IV, and you have to really be good. As a general rule, you normally don't place IVs in the AC, so you have to be good at placement in the hand or the forearm, or even using ultrasound IV placement. Another positive thing is from a paramedic, which your skills come into play, is that you may have to hang multiple drips before they go into surgery. But I think one of the best skill sets you have is that you have the ability to catch a situation before surgery that may cost them their life and be able to halt surgery. And I'll tell you a really good story. So one day I was working and we had an inpatient that came down. He was a renal patient, and uh, he was having surgery. So they ran labs that day, and the labs that day, I think his potassium was 5.2, which average potassium is 3.5 to 5. But when the nurse hooked him up to the monitor, uh, she said it didn't look right. She thought it was possibly VTAC, and so during that time, I was just making some calls for to verify for patients that was going to be coming in tomorrow, which was the next day. Just to remind them of their arrival time. And so she asked me to come take a look at the monitor, and so I got up and went and looked at the monitor. And first thing I noticed about the monitor was hyper acute waves. She thought it was ST elevation, and I said no, that's just those are hyper acute T waves. And so when I had her look up the labs that morning, and his potassium was 5.2, and I was like, "There's no way his potassium is 5.2." And I asked, "What is he here for?" And when she said renal patient, uh, alarms went off in my head. So first thing I did was told the anesthesiologist what was going on. Anesthesiologist had me use the iStat machine to run a potassium, and his potassium was 7.1. And so, of course, his surgery got canceled, but I also had to go into action. Had to give him albuterol, insulin, and D50. What we can do to get that potassium to go back into the cells. But without my paramedic knowledge, I really would have dialed in on his waves, coming across the monitor, his EKG. So that can kind of give you a little bit of idea of the kind of experience you need working in these areas, especially when you're monitoring these patients. So, what is the negative? To me, the negative is it can get boring for a medic, especially if you kind of still one in that medic field, still want to handle emergencies, and still like the feeling of knowing that you saved a life. You're not going to get it a lot of times in pre-op and endo. Now, some of these areas, like I said about catching this 7.1 potassium before he had surgery, that was a good catch, but that's not the norm. So uh, keep that in mind. It can get a little boring for a medic. Also, been around many CRNAs would probably make you want to go the CRNA route because you really get a good in-depth look at their practice. But to become a CRNA, you need ICU experience, which means you would need to move out of that pre-op setting. So hopefully you enjoyed this podcast. It kind of gave you a little bit more in-depth into surgical services, pre-op, and endoscopy, if this is an area that you may be thinking about choosing. So happy nursing, and I'll see you later. As always, hey, make sure you guys follow me on Instagram at Paramedic2RNFO. Remember the number 2.